Hey guys, welcome back to the Func Med Nation podcast. Today we're talking to Julia Malkowski, Dr. Julia Malkowski. She is a representative of Doctors Data. She's also a practicing functional medicine clinician. And I reached out to Doctors Data to speak to somebody on their staff because they have just recently come out with what is called an Antibiogram. And this is something that's been used in the pharmaceutical industry as part of a larger effort, if you will, called antimicrobial stewardship as it relates to responsible use for antibiotics and the impact on public health. And so today we're going to be talking about the Antibiogram, which is basically a distillation of data that Doctors Data has collected over, I believe they used 2022 as the reference year, where they looked at all their microbial sensitivity studies and came out with information relating to what the most, let's say, efficacious antimicrobial herbs are for very common bacterial and fungal species that we find when we do stool testing. So let me give you a little background on Dr. Malkowski, and then we'll get into the interview. She is obviously a staff doctor and part of the clinical education team at Doctors Data. She is a practicing clinician. She graduated from National University of Health Sciences as a chiropractor in 2016. In 2017, she graduated with advanced standing as a naturopath. So she's an NDDC with a Bachelor of Science. She has presented at Autism One, the International College of Integrative Medicine, the Institute of Women's Health and Integrative Medicine, as well as A4M. Been published in the American College for the Advancement in Medicine and the Townsend Letter, and she remains committed to optimal health on a personal and professional level. And here's the interview. Hope you enjoy it. All right, Julia. So before we talk about Doctors Data and the Antibiogram specifically, I want to know a little bit about your background, how you got into functional medicine, and then how you got connected with Doctors Data. So why don't you just kind of give us a quick synopsis of where you're coming from?
Yeah, thank you so much, Stephen. So with regards to my interest in functional medicine, it really started as a personal one. I had always somewhat been interested in eating healthy and organic food ever since high school. And then I had worked in a health food store, a few series of health food stores, Whole Foods back in the 90s. But then after my son was born, he actually was unhealthy in that he had a rash. So dermatological presentation. And his pediatrician, who was well regarded as one of the best doctors in the Chicagoland area, really, still a great doctor, but he had just sort of brushed it off as an infant rash, which didn't make sense to me because my son was past that age. And I, at the same time, was developing the same rash. So then he said, maybe it's just a detergent, atopic dermatitis, which again, didn't make sense to me. So I had at that point taken him to a naturopathic chiropractic doctor in the area. And she took one look at us and she knew that this was dairy intolerance and that previously my body had been able to compensate for that without presenting with symptoms. But after pregnancy and nursing, that my body just could not compensate for it anymore. And this was showing up in, large pieces, and that I couldn't digest it. My son couldn't digest it, and to eliminate dairy, and that should resolve within 2 weeks. Well, I eliminated dairy right after that appointment, and the issue resolved within 1 week. So that was wonderful results for me. And actually at that time, I decided to pursue a career in naturopathic functional medicine as well.
Yeah, I think so many of us that get into the natural health field have either a personal experience or an experience with someone very close to us that, makes that inspiration. My background was in business and advertising when I became inspired to become a chiropractor. And, I met functional medicine a few years after I started practice. So how then did you get connected with Doctors Data? Because I'm fairly certain that you're still practicing clinically and you have an association with Doctors Data. So how does that work?
I am very fortunate in that I reside outside Chicagoland area and was able to go to school here. And actually, Doctors Data is in the same location. So that was a wonderful opportunity to continue alongside clinical practice in the laboratory setting.
Right.
So Yes.
Yeah. And so how did you meet them? Well, like, were you connected with them maybe as a student representative? Did you run across them in a seminar somewhere? And who reached out and said, hey, Julie, we want you to work with us?
Yeah, it was actually it was a posting they were having. They were at that time hiring, and so I found that through my my alma mater. So they had that connection there.
Good for you. Good for you.
Yeah.
All right, so let's start with the big picture, and work our way towards the Antibiogram itself. And when I was doing research and preparing for our conversation today, came across this concept of antimicrobial stewardship, and we see this in the world of antibiotics, where biologists and specialists are calling for caution in the use of broad spectrum antibiotics because it develops, resistant strains, and this presents problems not just at an individual level but also at a community level, because we start breeding bugs that are harder to kill, and that has impacts on our neighbors. So can you explain to me the concept of antimicrobial stewardship, using antimicrobials responsibly, and then let's talk about how we translate that concept from pharmacy to natural medicine. So I'm just going to toss that over to you and see where that goes.
Yeah, great point. And Alexander Fleming once said something to the effect of that the person who carelessly utilizes penicillin is responsible for any adverse event or death of anybody based on that resistance there. So it really is something that everybody that is employing antibiotics and antimicrobials should consider. We see, we talked about the pediatric population. It's commonly given, antibiotics are commonly given even if you call and you say, my child has an ear infection, and you're giving an antibiotic over the phone, right? Just in case. So they are used pretty ubiquitously and with well intentions, right? Because they are effective and definitely life-saving in many of cases. But what we do see is that the antibiotic resistance is a serious consideration, and we can discuss that further, the mechanism of action. But as a lab, we know that we are providing information about antibiotics and antimicrobials. And so really, we do take heed in that antimicrobial stewardship efforts. So this is part of our laboratory practices.
Yeah, and I mentioned it before we started recording. I made mention, and listen, I might be wrong on this, but I have a sense that new practitioners, and maybe it's more pervasive, but there seems to me to be almost an unfailing trust in natural medicine as being safe across the board because it's natural. And we know that that's not necessarily the case. So do you, and does Doctor's Data as a lab entity, do they see the potential problems for microbial resistance patterns using natural medicine like we see with pharmacy?
Yeah, and that's something that we will take a look at as we continue to publish these antibiograms. So as you'll see, the data, we're going to be collecting it for a year and publishing yearly. That's fairly standard publications for antibiogram. So we can see the bacteria's reaction to the specific agents over time. And absolutely, I agree with your point. I do think that is very important in natural medicine, because sometimes within natural medicine, we need to understand we are employing it because it works, not because we're adhering to natural. So if it doesn't work, we need to find out what does work, right?
Yeah. And that's like I've always appreciated labs, for example, with stool testing, that publish microbial sensitivity, because it helps to guide. And, there's also a tendency, particularly with I'd say even with seasoned practitioners, you kind of stick with what you see works. And so, you tend to have a specific gut protocol that you might use with all clients, whereas that protocol may work really good for, say, 7 out of 10 patients, but for the last 3, it really doesn't. And so I think the advantage of microbial sensitivity testing is quite good. And when the Antibiogram came out, and I think I received an email that had it, I was looking at it thinking, like, this is actually really helpful from a clinical standpoint. And, one of the reasons why I want to periodically do these lab spotlights, if you will, where we talk to representatives from labs like Doctor's Data, is because I have a sense that you guys harbor a ton of information that if we could distill it into a usable form and get it out to functional medicine practitioners, it would really help inform how we do things and perhaps improve our, efficacy rates overall. Would you agree with that? And is this something that you guys plan on extending beyond the Antibiogram and start to mine your own data so that you're feeding information back to the Func Med community?
Exactly, Stephen. Absolutely. That is part of the purpose of the Antibiogram, is to share this internal data that we have been collected. As I said, is this antibiograms that have recently been published are collected over 2022, in which there were 10,000 samples. So there is a wealth of data. Generally speaking, for a hospital to publish, they need 30 samples of one specific bacteria. So we are fulfilling that criteria. And yes, exactly as you're saying, we do. Like. Pardon?
I said, it sounds like you're going way beyond that standard.
Yes. Yeah. So we do want to share this information, exactly as you're saying.
Yeah. Yeah. That's perfect. That's perfect. So let me ask a question again, because either I didn't hear the answer or we got onto something else, but do we expect microbial resistance patterns to happen with more and more doctors and people on their own using antimicrobials from the herbal field? Like, are we going to expect that, for example, grapefruit seed extract in 10 years is not going to work as well as it does for some infections today?
Mm-hmm. Yeah, that's a great question. I would hypothesize potentially, because again, the resistance is intrinsically due to the bacteria's survival mechanism. So that is going to be inherent regardless of whether the agent is pharmaceutical or natural. Again, with regards to dose and duration, there are nuances, and we know that herbals do have nuanced mechanisms as well. Maybe the pressure put on, example, Klebsiella from pharmaceutical agents, globally speaking, is greater than the pressure of Klebsiella from natural agents. But how will that influence the bacteria, and how will that change? It would be interesting to see. Yeah.
Yeah. And this brings up, and I think that's a great segue to talk briefly and high level about mechanisms of microbial resistance. And I know, like, that's a bunny trail, and it goes down to infinite detail all the way down to genes. But it kind of raises some larger questions as to how these different organisms have different, let's call them phenotypic varieties, right? And we know, for example, that there are different strains, if you will, of, say, H. pylori, some of which produce very, very damaging endotoxins, and some don't. And so, in the world of H. pylori, for example, if you're going to have an H. pylori, the one to have is the non-toxin forming one, as opposed to something that forms one of, any number of different endotoxins. Will there ever be a point where labs like Doctor's Data does a next level analysis of any one person's microbiome to the point where we see division of top level information into different strains or substrains, so that we can start understanding why a protocol I use in one person for the same infection doesn't work in the next person with that very same infection? And that might be a roundabout way, but I hope you understand my question there.
Mm-hmm. Yeah. I mean, it is a unique and nuanced consideration. I would say, with regards to addressing the individual, understanding the whole picture. So understanding their microbiome, their immune response. So if there's fecal secretory IgA, if there are any lactoferrin, calprotectin, things like that, that does play a role, especially the host microbiome. If you're going to employ an antimicrobial therapeutic, that does play a role, whether there's other infections, whether there's parasites, things like that. So looking at it together, and with regards to, specific bacteria and understanding there may or may not be a toxin present, an interesting case of that is C. difficile. So you can have C. difficile in the colon. You can be an asymptomatic carrier, or you can have C. difficile in the colon, and it may or may not be toxin producing. And so those are actually two separate tests: culturing for C. difficile itself, and then using the PCR technology to understand the presence or absence of the toxin. So yeah, that is important. Yes.
And do we have to account for this? And I'm trying to formulate the question that's in my head. And again, the clinical phenomena is a protocol that we would normally use for a given pathogen or potential pathogen works in one person, but not in the same person for the exact same infection. And my suspicion, again, is that we're seeing phenotypic differences in the potential pathogens. Like, just like you and I, we share human DNA, but phenotypically, you're quite different than I am. And so an H. pylori infection is not necessarily an H. pylori infection, and a Klebsiella in one person could be completely different than Klebsiella in another one. Will we eventually get to the point where we do have that data? Do you think that we get phenotypic reports?
Yeah, that would be excellent information. Treatment based on phenotypic variability of bacteria.
Really
yes.
Yeah.
To my knowledge, we're not quite there yet, but
Yeah.
who knows the way that things are advancing, hopefully soon.
Yeah, understood. All right, so let's talk about mechanisms of microbial resistance. And with my read of the literature, there are commonly, say, 5 or so different mechanisms that I think we can probably boil down into several different categories. And we can spend as much or as little time on this, but I think it's helpful to understand, or for clinicians to understand, that over time, these little sneaky buggers adapt, right? They're very smart, they're very evasive, and so they can modify their own behaviors based on what their external environmental influences are. And so they can have genetic defense mechanisms. They can change accessibility to the organism itself through changing cell membrane permeability. They can acquire what's called like target bypass systems, where it's almost like they put out a red herring and say, okay, go after this while I sneak over here and do my dirty work. So talk to me about the mechanisms of microbial resistance, whether or not there are certain ones that seem to be dominant. And again, I'm going to press on the question, in a world where we tend to think natural is always good, are we going to, again, see these same problems with the resistance patterns? And so let's talk about resistance mechanisms, if you will.
Yeah, exactly. As you mentioned, the bacteria are brilliant. We know that they actually outnumber human cells 10 to 1. So the question, the esoteric question is, who's in charge here?
Who's in charge?
But really, as you say, they are extremely intelligent with regards to their survival. So in the presence of antibiotics and antimicrobial therapy, we might get them, but they're going to learn to adapt. And an interesting fact as well is that in the presence of stress, so when we are stressed, they are actually going to feed on our stress catecholamines. So when we're stressed, we have excess catecholamines in systemic circulation. These spill over into the GI system, and then the bacteria feed on them. They love them. So even they're adapt to, to host physiology to extend their survival. So, and interestingly, they will share genes, they quorum sense, they talk to each other, they gene transfer. So they really are inept for their survival. So it's interesting in terms of, is it almost only a matter of time before they adapt to these natural agents? We will have to see.
Yeah, so and I guess the practical takeaway from that is that clinicians dealing with some kind of infection, whether it is GI, I mean, that seems to be the context of what most of this conversation centers around, is that we shouldn't really be getting locked into one-size-fits-all strategies. And, the tendency is to adopt our favorite protocol because it's easy to think about. It's, we set up our systems to deploy them easily, and so it's easy to write a recommendation or a prescription for things that we've always done, as opposed to constantly have to think about, well, how do I deal with this particular infection? So as far as adaptability, you mentioned quorum sensing a couple of times. I'm familiar with that in the context of biofilm formation. How does this relate to microbial resistance? Is it in context of biofilm formation? Is that what you're referring to?
Yeah, so there is bioform formation, and everything in the colon with the bacteria is about balance. So they are going to feed on the information that's around them with their environment and adapt, essentially. So
Yeah.
bioform formation is part of that. Yes.
Yeah, understood. How many are you guys at some point going to, if possible? I mean, I've made this request to other labs, like to have a test that actually tells us if biofilm is involved in a particular GI case. So far, we haven't seen that. Is there any rumblings that you or any other lab might be working on that?
Well, so essentially, a consideration there is that biofilms are present on potentially beneficial bacteria as well. So they really are an integral part to the whole system. Yeah. So if we're going to talk about that, we can't necessarily just. Yeah, it's an interesting consideration if it would be possible to just test the biofilms on a pathogenic or dysbiotic bacteria versus beneficial. But yeah, biofilms are an integral part of the bacteria in the GI tract. Yeah.
So would it be, and I'm trying to read between the lines as you answered that, is it a circumstance where we perhaps shouldn't blindly go in and start blasting biofilm with disruptors because we could be disrupting the matrix in which the microbiome lives, the beneficial portion of the microbiome?
Exactly, Stephen. You hit the nail on the head there.
Yeah, exactly. Yeah, I could sense it like there was something that you weren't quite saying, and yeah. Okay, so we'll just leave that where it is for the moment. So let's talk about the Antibiogram project itself. Let's start by defining what an antibiogram is, and then maybe you can tell me whose brilliant idea was it in doctors' data to say, let's do this.
Yeah, so an antibiogram is, like we're saying, historically these have been used in hospital settings, and in hospitals, if they culture a Klebsiella from, let's say, a wound, from the blood, from the respiratory tract, they're going to keep track of that bacteria and what it was susceptible to understand antimicrobial resistance over time. That's what that is about.
Right.
Now, at Doctors Data, we are very fortunate because our antibiogram data is just from a stool. And so there is there's a theory that with regards to antibiogram data, they actually should be organized by site as opposed to bacteria, because exactly as you said, there's multiple considerations that do play into the physiology of the host site. So we've already taken that factor out, and this is all stool. And so exactly as you said, this is important with regards to individualized medicine. And we have had this data historically collected because we are performing this on every dysbiotic bacteria and yeast that we receive. So there's a wealth of information, and we wanted to provide this clinically useful information to physicians actually around the world.
Whose idea was it?
So this was a collaboration between the Doctors Data executives as well as the microbiology department and clinical feedback from clients.
So how, and this is not a question I had planned on asking, but I try to stand in the gap and ask questions that I think anyone listening would ask or would want me to ask. So how is Doctors Data structured in terms of having a scientific advisory board, a microbiology team? In what advantage is it from a diagnostic, just a laboratory standpoint? I mean, I think I understand what it might be valuable to us as clinicians, but why have a team of microbiologists on staff?
Yeah, so we do have microbiologists actually in the lab performing the testing. So when the Doctors Data is a clinical education, but there's also a laboratory on site. So the samples are sent to Doctors Data, and they are processed at the lab there. So there is a CLIA certified lab there, and within that there are excellent microbiologists, and that's something that makes Doctors Data really emphasizes these excellent microbiologists and excellent parasitologists, because in terms of microbiology, this was historically the standard of care, the gold standard, and it still is for evaluating bacteria. But now we have the new kid on the block, the PCR, the DNA data. And so that's another story, but we've really integrated both, yet still keeping those expert microbiologists. And that feedback is valuable. Their expertise and the information is very important, because microbiologists do have a little bit of a different experience than clinicians. And so having all of that information together is important. Yeah.
Yeah. Do you have anybody particularly on your team that you feel bridges that gap well? Because you and I both know the world of clinical practice it requires a different mindset and perspective than good research. And so it's rare to have clinicians who are researchers, although it certainly happens. And it's also rare to have scientists who understand the clinical side of things. So do you have somebody that you feel really kind of fits that role and sees the best of both worlds?
Yes, well, we do have Dr. Joel Mortensen, who's a medical doctor microbiologist from Cincinnati Hospital, and he works with doctors' data. And then we also have Hope Belfus, and she is the head of the microbiology department, and she brings a wealth of knowledge and data and expertise.
Yeah, and I think it's comforting.
Get a chance. Oh,
I'm sorry. No, go ahead.
I was going to say we do get a chance to work together. And so I think that's really able to take everything to the next level when these different groups of people are working together.
Yeah, and I think it's comforting for me as a clinician to know that labs that I use or consider using, have that ability to bridge those two different worlds.
Yeah.
So let's look at, I've got it up on my screen. And of course, if people are listening on any of the podcast platforms, and I am recording this on video, you can see it on YouTube. With your permission, I'll also put a link in the episode description for the podcast so people can download the Antibiogram, and it'll be linked to Doctor's Data website and so on. And so I've got it shared on my screen. This is the first time I've shared stuff on my screen, so I hope that I'm doing it right. Can you see it there? And can you walk us through this first section where we're looking at susceptibilities to different natural compounds for bacteria?
Yes, absolutely. I can see that. So here we have the common dysbiotic bacteria. So these are the bacteria, we have Aeromonas, and then we have Citrobacter. We have some Citrobacter species there. So what this information is, this is the information based on every single time that these bacteria were cultured in the lab. These are the results within those within the agar plates. So this is the percentage of how many samples were susceptible for the bacteria, and then the percent of highly sensitivity for the natural agents. And so we can see with the bacteria, we're starting with ampicillin, and then with the natural agents, we're starting with silver. So as an example, Aeromonas, 0% of the samples were sensitive to ampicillin. And then with that, if we move along, we can see that 99% of the samples were sensitive to silver. So that means the percentage of how many of the samples were sensitive to that agent.
Now, I'm glad you made that distinction, because when I looked at this, I interpreted this incorrectly as the effectiveness of the rate of killing. That, for example, silver killed off 99% of the organisms in the sample, but you're saying, if I heard you correctly, that in this case of Aeromonas, 99% of samples were susceptible to silver, but that doesn't necessarily mean that silver killed everything, right? Completely
Correct.
Eradicated the infection. So when you say that they were susceptible, how do I, as a clinician, look at any of these numbers and understand whether or not, even though every sample was affected, maybe the effect was mild rather than very effective in half the cases? Like, how do I, as a clinician, start to parse that level of detail, if that's at all possible?
Well, yeah. So if we look at, let's just say Klebsiella pneumoniae, that's a very, very common dysbiotic bacteria. So with this one, for the percent susceptible, 0% were susceptible to ampicillin, so that would not be our option. And then with the amoxicillin, clavicillin acid, clavinic acid, this is 98 ceftazidimide is 100, sulfaxacin is 97, ciprofloxacin is 99%. So you have that choice there. You really want to use something that is in the 90s. That would be the best option. And then in terms of mild, you would say, like, example, berberine, that 4%, that's mild. So those are your options. I would say even the 11%, the black walnut. Oh, excuse me, I'm on the wrong one. 7% for the Klebsiella, that's mild. That's pretty low.
Right. So again, just to make sure that I'm understanding, this is the number of samples that showed some degree of sensitivity or susceptibility, but it doesn't tell us the magnitude of the susceptibility.
So for the prescriptive agents, the percent susceptible, that is based on the CLSI guidelines, and that's the Kirby-Bauer method. That is well established, and that's what the microbiology department is using. And that is based on zone of inhibition in the agar plate.
Right.
So when the bacteria is in the agar plate, and then you're putting the prescriptive agent on there, there is matrices and parameters to understand zone of inhibition that will delineate something as susceptible versus not susceptible. That's well established. And a similar methodology has been used for the natural agents. And so that it's based on laboratory standards, essentially, to decide what makes something.
For anyone who's not familiar, can you, and I know you named it the Kirby-Bauer method, but can you explain what this whole zone of inhibition really is and how that works? And I have a fundamental understanding, but how does that work, just so that people in practice know how labs are figuring this information out?
Yeah, so essentially with doctors' data, when there is a dysbiotic bacteria in the sample that's been cultured, we will actually take that isolate from your patient's result and put it in Petri dishes with each prescriptive agent and then with each natural agent. And in that Petri dish, it's on an agar plate, and the prescriptive and natural agents will be added. And then from there, that's where I'm talking about the Kirby-Bauer method. This is a standardized microbiology methodology to understand if an agent, if an isolate is susceptible to the agent, and it's based on the zone of inhibition. So when you put that prescriptive or natural agent into that agar plate, it is they measure how much of it has been killed. So I believe the zone of inhibition in millimeters is, if it's less than 15 millimeters, that is considered resistant. And intermediate is going to be 15 to 20 millimeters, a zone of inhibition. And then if it's susceptible, it'll be greater than or equal to 20 millimeters, meaning when that agent was applied on that bacteria, it killed it over a 20 millimeter surface area. Right. So then that is a laboratory standard. So we're using those agreed upon standards.
Right. And so in my mind, I try to translate it into something that I can think about with an image. And so I'm imagining that the agar plate is circular and the sample is spread evenly across the whole thing. And then the inhibitory or potentially inhibitory agent is plopped right down in the middle, like the bullseye of a target, and then you just figure out how much or how far away from that central point the concentric rings of inhibition occur. So again, and I'm sorry if I'm repeating myself, but I want to make sure that I get it right, and if I am, press to get more information. In the Antibiogram, what we're seeing is the number of samples that are susceptible, but it's not telling us how much inhibition there is happening. Or are you guys applying your own standard and saying, well, we'll only say that if something is sensitive or susceptible if it exceeds beyond a certain zone of inhibition? So we can be confident 100% of the samples are going to be eradicated given enough time of application.
So, we're not applying our own standards. These are, again, the CLSI guidelines. And so if something is susceptible, it basically hits that that metric to say, okay, this sample is susceptible, check. And then that goes in the susceptible category. Otherwise,
Gotcha.
for the prescriptive agents, if it's not susceptible, if it doesn't hit that matrix,
Yeah.
it's not in the susceptible category. So with regards to if something is resistant, if it's not susceptible, then it's considered resistant. That's the consideration, right? So Aeromonas is resistant to ampicillin. We can see that there with 0%.
I got you. Yeah. And again, my apologies. I just want to make sure that I have the perspective correct on that.
Yeah.
I'm trying to scroll down here. Well, actually, no. Let me ask you a couple of questions while we're here. Some of the things that I saw here that surprised me were, for example, what seems like an astounding success rate across multiple bacterial species with things like Uva-ursi. I mean, I make pretty frequent use of things like grapefruit seed extract. I have a high trust level with that. I don't often use Uva-ursi. I mean, I do in typically blended formulas, but I don't know that I've ever prescribed as a single therapy Uva-ursi in, for example, a Klebsiella. But I'm looking at this going like, well, maybe I should think about that. So what kind of surprises, if any, came out of the natural agents for you when you started to look at the data? Were you surprised by anything?
Yeah, so Uva-ursi, we generally think of that of the genitourinary tract, not necessarily the gastrointestinal tract. So that is a surprising finding. Along those lines as well, berberine. I think that generally speaking, there is an ideology that berberine is extremely effective against bacteria, but we do not see that here.
Yeah, and that kind of raises another comment, perhaps question, is that we tend to, like you said, like Uva-ursi, most people think, well, genitourinary, they don't think gastrointestinal. And we tend to pigeonhole things or characterize certain natural agents as, well, this is what this does. And we don't really understand perhaps alternative uses. Berberine has many other bioactive effects, but it seems like it's not all that effective for at least bacteria. Did you have any other surprises? Well, I don't want, no, let me pause that because I want to go and talk about the fungal at some point. So any other surprises in the study that you guys have published here?
No, I think, with the ampicillin, that makes sense. It's very narrow spectrum. With the natural agents, the Uva-ursi is something that comes up. The oregano is interesting too, because that's generally talked about as, broad spectrum. But yeah, and that's why this information is so important, because we do want to use individualized data. Yeah.
Yeah. And so this is aggregated information. And so I have a question about how this was done. Did you guys take samples from many different people and homogenize them? Or did you take select samples of individuals and test them individually, like we would get a report back with microbial sensitivity on one individual's stool sample? Is this aggregated information so that, going back to the whole phenotype question, if there's a diversity of bacterial or microbial phenotypes, that we can't necessarily expect one thing to work in one person for the same infection, are we seeing information that's going to help us feel comfortable that across a broad spectrum of population of people with different types of microbiome challenges, we can consistently expect Uva-ursi in everybody to do a good job for bacteria? We can consistently expect grapefruit seed extract or silver, for example, to work across broad populations.
Yeah, and I would say, generally speaking with data, there are limitations, but the consideration here is that this has been collected from every single isolate that was individually performed during the year. So example, if you had a patient report and on that patient report, they came back with the Morganella, a Klebsiella, and a Candida, each time those are performed individually and reported on your report per your patient's individualized results. But at the same time, we keep a record of that data and put it here.
I see. Okay. So you didn't take a bunch of samples, homogenize them, and then perform susceptibilities. you collated the information generated by all the different reports that you generated in 2022, I think you said, and said across the board, okay, now I understand. Okay,
yeah.
yes. And that's a smart way to do it. I mean, obviously it would be not necessarily so technically challenging, but time consuming and perhaps certainly more expensive to have to repeat all these tests, right? If you were to homogenize samples and actually perform it. Okay, understood. I'm trying to figure out how to scroll down to the second page here, and I have not figured out how to do that. Sorry, Julia, I don't know how to scroll to the second page, but maybe you can just talk us through the fungal aspect of this.
Yeah, so for the yeast, there are quite a few species of Candida. A good amount of the report is Candida, about 60% of the report. And then we have some other species like the Geotrichum, the Cryptococcus, the Saccharomyces cerevisiae, and Boulardii is on there as well. Yep. So that information is presented as well. One of the findings with that is that nystatin is pretty effective across the board. So that looks pretty healthy. With some of the others like fluconazole or ketoconazole, there is variations. So, a Candida albicans can look very different than a Candida krusei. So that's good information. And then, so with regards to the natural agents, again, you see some efficacy for uva ursi. This does vary a little bit more than the bacteria, and you do see some efficacy for garlic, oregano. But again, I would say that there is more variability with those. Caprylic acid does have very good sensitivity, broadly speaking.
Yeah, and I would say that most companies, supplement companies making antifungal formulas have caprylic acid in them. What's surprising to me here is the performance of berberine as an antifungal.
Yes. Good point. Yes.
Yeah. And that goes back to what you were pointing out, and I was echoing, is that we tend to pigeonhole things and think, well, berberine is antibacterial. And so we wouldn't think necessarily to use berberine with, say, a candida infection. But now, of course, we should rethink that.
Absolutely. Yes. I'm glad you pointed that out.
Yeah, it seems across both of these categories, bacterial as well as fungal, it seems like grapefruit seed extract is performing pretty well as a monotherapy. What is your sense, and I don't know if the lab has done this, and it might be a suggestion, what about combination therapies? Like what if we added extracts of grapefruit seed extract and caprylic acid in one of these agar plates, or as you do your microbial sensitivities. And so, is that even a fruitful endeavor, or do you feel like you guys are accomplishing that by testing the compounds individually? Would you expect them to perform differently if you put them on the same agar plate?
That's a great question. If they would perform differently, I don't know. And again, we're talking about in vitro information versus in vivo. So we always need to put that caveat out there. This is, in vitro. We're trying. I think for our purposes, I don't believe there have been discussions to utilize dual therapeutics under one agar plate. Yeah. I do, do understand that in vivo, potentially using natural agents, you would use two as opposed to potentially a monotherapeutic. Yeah, that is commonly performed.
Can you, would you do me a favor and ask some of your microbiologists on staff, like if in their mind, would they expect to see different results if they combine them on one agar plate as opposed to test them separately?
Yeah, I can ask. I do know there are unique considerations when you're using something in the lab versus in vivo that they have to think about acidity and different things like that. But yeah, I can ask and see if they have any info.
And that's why I'm a clinician and not a microbiologist.
Yeah, same.
So what is missing from this antibiogram is parasites. So is that in the works, or is there some technical reason why that's not even a practical thing to do?
Yeah, there is a technical reason why that's not a practical thing to do. So if you'll notice with the doctor's data reports, these sensitivities are provided for bacteria and yeast. And the way that is performed, and maybe we should have said this at the beginning, is when we receive the sample, we are taking that sample and putting it under different growth media and growth conditions to elicit the growth of bacteria and yeast.
Yep.
Once there is a bacteria or yeast grown, that isolate is directly taken into the agar plates. But the step, which we did talk about that, but the step previously is we have to actually grow the bacteria and yeast from the sample. And that's, again, where that expert microbiology department really comes in, and they play a significant role. So that's how we're testing for bacteria and yeast. Especially when we're doing sensitivities. We are doing some testing via PCR, so we can talk about that later, but the parasites is a unique consideration. And again, within the microbiology department, there is a department of parasitology. So these expert parasitologists are combing through the sample under the microscope to identify the parasites themselves. Now, although, let's take it back a few steps. During the collection process, when those parasites are collected, they are put in a vial that has a fixative right away. So once the sample is collected and put in the vial, that fixative kills them. That way, they stay exactly as they are in the stool, so that the parasitologist can identify them under the microscope. So they're already dead. We cannot perform sensitivities on something that is dead, because again, the whole sensitivity process is taking that live isolate and seeing what kills it.
Sure. Yeah, no, that makes total sense. So I guess a related question to all of this information is creating a report. And I know you have the data, whether or not you guys have put it together into some form that you can share with us. But, it strikes me that, and I've been doing functional medicine for 15 or so years now, and stool testing throughout my entire career. I don't often see things like Candida albicans. Right? There was a time when everything was blamed on Candida. Right? Candida was the boogeyman. And just, throughout my own career and all the testing that I've done, I certainly see multiple bacterial species far more frequently than I see any fungal infection, particularly, and quite often I see other Candida species or Candida species other than albicans. Do you have any comment on that? Like, do you have a sense of what your data bank shows are the most common things that docs like me and you in practice are going to see when they get a report back?
Yeah, we do see Candida, and that's actually what we've put on these we do see Candida albicans, and that's what we've included in the antibiograms are the most common. With our culture methodology, we are culturing over 300 species of yeast, of which 95 species are Candida. So we do see Candida albicans. Now, this does highlight the importance of stool testing, because when you're performing a stool test on your patient, you can see what is exactly there, as opposed to adhering to some, incorrect dogma that was previously presented that yeast is the cause of, the everything. Panacea of health conditions.
Yeah. So, and again, just based on my experience, and I understand that I only see what I see, right? And I don't see what other practitioners see that I don't, and I don't know what I don't know. What seems to be missing from the list of that bacteria are a couple of things that I see on a frequent basis, and that would be things like staph and strep in the stool. So am I to interpret their absence from this list as that in the world of doctors' data, you guys just don't isolate staph and strep? You don't see it? Or is there a reason perhaps that you don't test for it if you don't test for it? I'm sure you do.
Yeah, great question. So in the colon, staph and strep are broadly categorized as imbalanced commensal bacteria, meaning
Right.
they take up space in the colon, but they don't exert significant physiologic function. Obviously that's very different than if we found them in the wound or something of that condition. But in the colon, they're really going along for the ride with the other bacteria. The caveat is group B strep in a pregnant woman. That's a different consideration, but broadly speaking, the strep and staph are just ubiquitous amongst GI physiology. And when they are found in the colon, they're really just taking up space. They're contributing to the community, but they don't exert significant GI issues. With the organisms presented here, these are associated with adverse GI events in terms of loose watery stool, things like that.
Okay, so that raises another question, that if it is the focus of this testing and the parsing of these lists to, as you say, distinguish acute or chronic GI symptomatology, because I'm trying to step back and see the bigger picture. Let's say that we have a kid with PANS or PANDAS, and they've got neurological autoimmune cross-reactivity from streptococcal enzymes. And so is it possible that a strep finding in the gut, in one case, even if it's an overgrowth, in one case would be clinically irrelevant, but in another could be, but the manifestation is not GI, the manifestation is neuroautoimmunity? Would that be a possibility? Or is the perspective from the microbiologists that staph and strep, even if they're overgrown, are inconsequential to human function?
Right. Great points. So that is a unique consideration that would be unique to clinical practice versus microbiology. Exactly. And the information that we are presenting here these are acute GI bacteria.
Yes. Understood. I got it for sure.
And again, from an antimicrobial stewardship standpoint, we do want to reiterate that bacteria or yeast within normal limits do not necessitate treatment. So as an example, in our reports, yeast that is considered within normal limits, because there is yeast within the human colon, to circle back to our previous discussion, there exists a reasonable amount of yeast within the human colon within normal limits. And so in those cases, we do not provide sensitivities directly on those reports because that is within normal limits. And that's part of antimicrobial stewardship, is treating what's outside the reference interval only.
Yeah, and I have this discussion sometimes when I'm going over stool reports with clients about how we have these reference ranges, and as long as an organism's population is below that, we have a reasonable expectation that it's not a problem. Where do those numbers come from, if you know? And if you don't, maybe we could ask your microbiologist another question. But where do we get this connection between the lab data, the reference range? Is it simply by analyzing stool samples of healthy people? Is that how they derive the reference ranges?
So in terms of that, again, there is a consideration there. There's clinical considerations, there's research, but then there's also laboratory data to determine with some of these bacteria. As an example, Klebsiella pneumoniae at small amounts is considered within normal limits in the human colon. It's not associated with GI symptomatology, yet when it is outside that reference interval, it's considered dysbiotic. It's associated with GI symptomatology. And again, that goes back to the point that the colon is a really dynamic environment. It's not black and white. And so we're trying to represent that. And so, so it's a variety of considerations.
Yeah, that presents a particular challenge to us as clinicians in communicating with lesser educated people in the realm of biology, meaning our patients, because most of us clinicians are not biologists, and most of our patients certainly are not. And so there is this tendency that if there's, to borrow from an old chiropractic saying, if there's a high spot, pound it down. So if there's, if you have something that shows up as positive, even though in our clinical estimation, it might be, basically a nothing burger, how do we communicate to people that in their particular circumstance, this is not a target that we want to go after. Because you know what it's like. If someone says or sees a positive finding, they want us to do something about that.
Yeah. So the nice thing about GI 360 is we have trying to think of how many categories of bacteria there are, because within the culture page, there are 3 categories of bacteria and then 2 categories of yeast. So we're culturing, the direct pathogens. So that's going to be, Aeromonas yersinia, those direct pathogens, C. difficile, the direct pathogens. So that's one piece of information. Then we have a second category, which is called imbalanced bacteria. And again, those are the bacteria like we talked about, the staph, the strep, the parasanguinus. These are oral cavity bacteria, skin, dermatological bacteria that are just in the colon. Then we have a third category of bacteria, and that is called dysbiotic bacteria. And then these are bacteria that are associated with acute GI symptoms. And in that case, only those bacteria that are cultured under dysbiotic will receive sensitivities. So the other bacteria we let go, but then the bacteria that are cultured as dysbiotic, and a few of the pathogens, then we take it from the next step into the Petri dishes and report that at the end of the report. So you have the individualized informations for the bacteria that are treated. Good. And then for yeast, exactly as I said, when yeast are cultured at a small amount, we do not provide sensitivities, but we do report that to you. And then when yeast are cultured at a larger amount, we take that isolate again and put it directly with the agents and have that at the end of the report.
Understood. Okay. And now you mentioned GI 360, and I've done a handful of these recently. I do most of my ordering through Rupa Health. Great. And so talk to me about the technology, because I've been around long enough to remember when Metametrics, which is no longer in business, brought PCR testing to the world of stool testing, and they caused a huge splash. And of course now there's this, and I don't know if it's been settled, but there seems to be a couple of different camps about the value of PCR testing. And some labs do that exclusively. Others, it seems like Doctors Data, it seems to me that your technology strategy is to use the best technology for certain things. Is that correct? And if so, can you explain microscopy, MALDI-TOF, and then PCR, which I believe are the 3 different strategies you're using in terms of technologies? Am I right on that?
Yes, exactly. You're right. So for bacteria, it's going to be that PCR data, and then it's going to be the culturomics via MALDI-TOF.
Okay, so explain MALDI-TOF.
So MALDI-TOF is the I'm trying to think of the exact mnemonic there, but it's the time of flight mass spectrometry, in which once the bacteria is cultured. So we talked about how we're taking the sample and putting it in different growth media to elicit the culture of bacteria and yeast. That's one step of it. Then once it's been cultured, we need to identify it, right? What is it? And so the MALDI-TOF essentially is going to identify the genomic fingerprint of each isolate. And then it's referencing a library that is a worldwide library, and it is identifying it via the genomic fingerprint. So that's how we're identifying the bacteria. This is essentially an open-ended list because we can identify new bacteria this way, or sometimes we can speciate out different bacteria. But yes, that is the technology that we're using with GI 360. And that's how we are identifying the bacteria that you see right here in the antibiogram.
And so you said when you were describing the MALDI-TOF, which my understanding is it's like a laser assisted mass spectrometry type thing. And again, that's not my deal, but that's my basic understanding. But you said that you're identifying the genomic fingerprint. Isn't that the same thing as what PCR does? And if not, what's the difference?
So with the MALDI-TOF, it's using that laser to identify the genomic fingerprint. With PCR data, you're looking for the DNA or the RNA of the bacteria.
All right, so this is where my knowledge starts to break down. To me, it sounds the same. Like we're still testing genetics. So what's the practical difference? Like if, let's say somebody listening here is using a lab that only does, PCR testing. What is it they're missing? And maybe I should preface this. Like when I teach functional medicine seminars and we get to the GI section of whatever topic it is for that weekend, I will quite often tell the docs that are in attendance that, listen, no matter which lab you choose, you're going to miss something. And we can't expect, if you did a split study and took one sample and sent half the doctor's data and half to one of your competitors, I would not expect to get the same results back because the two labs use two different approaches. Can you kind of address that whole thing if you feel comfortable doing that?
Yeah, so there's, there's multiple points here to discuss.
Yeah.
So first of all, I would say the difference with the MALDI-TOF and the PCR is the culture. So with the PCR, you do not need to culture. That's different. With the MALDI-TOF, you're culturing and then you're identifying from that culture the genomic fingerprint. So you need the culture, and the culture is very important. Don't underestimate the methodology and the expertise that go into that. That's a step. Once it's been cultured, then you can identify it via MALDI-TOF. Now, exactly as you're saying, each has its own limitations and benefits. So with the PCR, this is excellent because it can identify, it's very sensitive and specific, so that identification is there. And with that, though, it's basically akin to if you're going fishing and you have a rod with a specific lure, you're looking for a specific fish, you're going to miss whatever else is swimming in the ocean. With the culture and the MALDI-TOF, what we're doing is we're just taking a wide net, basically. We're throwing it out there, catching whatever is there, and then culturing it, right, in the growth media, and then identifying it with MALDI-TOF. And so with GI 360, the thing is we've actually combined both to to alleviate exactly what you're speaking of, the limitations inherent to each, because PCR is very sensitive and specific, yet it can only identify what it's looking for. MALDI-TOF is great information. You get a large piece of information. Culturomics is still excellent. It's still the gold standard. But as you mentioned, that new kid on the block, PCR is available. So let's see what we can get with that as well.
Right. So is it a case where organisms that might be more difficult to identify through MALDI-TOF, those are the ones that you're using PCR for?
So not necessarily, because again, the culturomics is excellent and the microbiology is excellent. The two cases that we're using PCR for are, number one, pathogens. PCR is excellent for pathogens because it's very sensitive, it's very specific. If you want to find out why your patient presents with acute gastroenteritis of known origin, you want that information and you want it right away. PCR, you're not going to take the time to culture and you're not going to take the time to go through all that. You want to know exactly what it is right away. Right. So we have a pathogens panel on GI 360 looking for the 11 causes of acute gastroenteritis, the most common causes. Another consideration there is viruses. You can only use PCR data for viruses because we're not going to culture them. Then the last consideration is, outside of pathogens, what are you looking for with your lure? Like, what exactly are you catching? And so that's what makes GI 360 unique, in that our PCR portion is about 45 different analytes that have been studied over 5 years. And those specific bacteria in their specific makeup, quantity, et cetera, is associated with dysbiosis or a normal biotic reference range. And then we're also looking at the matrices of abundance and diversity within that category. Yeah. So if that makes sense, PCR is excellent information, but you have to understand what you're looking for and why you're looking for it.
Yeah, no, understood. And I like the perspective of, we're going to use the most sensitive and specific testing for the things that are true pathogens. That makes sense to me clinically.
Yeah. So
Which
all of that is in one test.
One test, right. And so what technology and approach do you guys use to assess the microbiome? I should say the probiotic portion of the microbiome.
So we start with the microbiome abundance and diversity portion of GI 360, which is based on those 45 analytes that have been studied to associated with dysbiosis in a normobiotic reference range. So the excellent thing about the GI 360 is that the normobiotic population is well defined, and then the dysbiotic population is well defined. This has been studied in individual patients with regards to IBS, IBD, obesity, diabetes. So that's a key point about the microbiome is with PCR, you can get a lot of information, but at the end, how does that clinically translate? What can we do with that information? And so with GI 360, we've provided that information based on the fact that we have a normobiotic reference range. We have a dysbiosis index score. So your patient's result has a score of 1 to 5. 1 and 2 are healthy normobiotic guts, and then 3, 4, and 5 are dysbiotic. We have a diversity score, and then we are taking it down further into functional guilds. So out of the 45 analytes, you're welcome to go through every single analyte and evaluate those. But at the same time, if you want to look at the functional guilds, the specific bacteria that are associated with health outcomes. So that's going to be the butyrate producing bacteria, the bacteria that are associated with inflammation, the bacteria that are associated with mucosal barrier integrity. You're going to see if those fall within or outside the reference interval.
Yeah, and those are correlations, you're not implying causation, correct?
So, that's a little bit of a tricky one. I would say that it's not necessarily causation, but it's understanding the foundational considerations. I mean, with regards to example, mucosal barrier integrity, you can say that if those mucosal barrier bacteria are outside the reference interval, you can have decreasing mucosal barrier integrity, which can lead to intestinal permeability. So it's a consideration.
Yeah. How many layers deep do you guys get into your microbiome portion? Like, you can look at the top level view of, say, Firmicutes and Bacteroidetes, and then you have, and they represent what, 93 or so % of the entire human healthy microbiome. And this is my opinion, just based on my own observation and clinical experience. It seems to me that there's a level of detail that some of the labs are, and I'm not pointing to you guys, but I'm just saying that there are some labs out there that go to such a level of granular detail with the microbiome that I think it just starts to go beyond anything that we can confidently and intentionally shift or manipulate through some kind of, say, a dietary or probiotic strategy. And I guess what I'm trying to say is, it seems to me that we're in an era right now where we can test for a lot of different things that we might not know much about. We don't know how they behave. We don't know how to affect them. We don't know how they affect human health and well-being. And maybe we're still in an era where a top-level view of the microbiome is much more practical and usable for us clinically than all this infinite detail that not only overwhelms me as a practitioner, but certainly overwhelms the people that we're presenting the information to. And maybe I'm asking you to take off your doctor's data hat and talk to me more as a clinician than as a representative of the lab. But what's your sense of that? Like the gap between usable information and overload of information?
No, exactly. I agree with your sentiment 100%. So with regards to that kind of goes to what I was talking about earlier. And you might be alluding to what's called shotgun genomic sequencing, in which we can get, pages and pages of data that we could never even read about the bacteria in our gut. But what does that mean clinically? Right. That might not be the most helpful clinical information. And so that really is why with doctor's data, the way the test was developed, not to bring it back to GI 360, but it does answer that question, because the way it was developed is they took all of that information, but then they looked at specific populations of people that had normal biotic gut as opposed to people that had diagnoses of IBS, IBD, obesity, diabetes, and they looked at the microbiome in between those groups and were able to delineate patterns, and that's where the dysbiosis index is derived from. So that's why doctors' data brought on that PCR technology into GI 360, is because of the clinical relevance. Now,
Yeah.
with regards to your question about, taking a broader view, I would say, based on all of my research and understanding about the microbiome, if you wanted to hang your hat on one piece of information, it would be diversity. How diverse is your gut microbiome? Because that is associated with health outcomes. And you don't need to get down to the species level, but that piece of information is very broadly reaching. Yes.
Yeah, and I've kind of gone very far away from probiotic monotherapy, right? And I think that we're, like I said a moment ago, we're in an era where we have potentially have so much visibility about infinite detail. And to think that I'm going to give somebody one strain of a lactobacillus and I'm going to shift that entire very complex picture it's no pun intended, it's like a crapshoot, right? You're just throwing something in there hoping it's going to do something good.
Yeah, and I would advocate that monotherapeutics do not have a place within the colon, generally speaking, if you're talking about the microbiome and foundation. Obviously, acute pathogens, that's a different situation. But one thing I will mention here is that with regards to the efficacy of probiotics, did you know that microbiome diversity may precede the efficacy of probiotics anyways? So again, it goes back to diversity and understanding the ecosystem in its entirety.
Yeah, and I think, and I've seen a little bit of hinting, if not some people stating it outright in microbiome research, that it's far better to use dietary change and prebiotic strategies than it is to use probiotics themselves. Would you agree to that as a clinician?
I would wholeheartedly agree to that as a clinician, as a researcher, and actually based on the reports that we see at doctors' data as well. Yes.
Yeah, very cool. Very cool. All right. I know our time is probably running short. I do have a couple more questions that I want to fire at you. And thank you so much for bringing us through this. This has been, you've confirmed some of my suspicions. You've clarified some of my confusion, which is exactly why I like to talk to people who know things that I don't know. Talk to me a little bit more about doctors' data in general, because you guys, it's not only the GI 360, you guys have been around for a very long time. What is it, other than the stool testing, do you think that you guys do very well that practitioners like me should look into and take advantage of?
Yeah, doctors' data is excellent because we do offer a variety of tests to understand physiology. So we talked about the GI 360. We do offer stool testing. We also offer salivary and hormone metabolite testing. We offer testing to evaluate elements and metals. We're looking at methylation. So we have a plasma methylation profile to understand functional methylation cycle, in addition to that genetic step, looking for the polymorphisms.
All right, let me pause you and ask you, what do you mean by the functional methylation? What's the difference than just getting a SNP report?
Right, because SNPs are static, they never change, but that doesn't tell us how the enzymes themselves are functioning. So we offer a test that measures methionine, SAM, SAW, homocysteine, cystathionine, and cysteine. So it can show you exactly how those enzymes are functioning, and you can address accordingly.
Yeah, so you're looking at the inputs and the endpoints of any potential SNP that might be there.
Exactly.
Yeah, very good. All right, and I'm sorry I cut you off, but I wanted to clarify that mostly for myself.
Yeah, absolutely.
Yeah, so again, finish your list of things, and then I just want to ask a couple more general questions. So what else does doctors' data do that's helpful?
Okay. Yeah. So, like I said, we offer a variety of tests, urinary neurotransmitters. Our cardiometabolic profile is excellent. And we do offer serum zonulin. That's unique for intestinal permeability. Vitamin D by blood spot. That's unique as well. So, and with your doctor's data account, if anyone has an account, you can call us if you have a case and say, what do you think would make sense for this case? Because with that large repertoire, we also have a hepatic detox profile, RBC glutathione. So, we can kind of point you in the right direction. Yeah.
So tell me a little bit more about the cardiometabolic I have another podcast that I do, which is public facing, and I've just recently been on a rant about statin drugs and cholesterol, and so everything cardiometabolic is top of mind for me right now. What's included in the cardiometabolic panel?
Right. So as you may be aware, with statin, it's really based on that cholesterol level, and that cholesterol is really only one piece of the picture. And you might know this, but I was looking into recently the historical values for cholesterol and how that has changed over the years. But we are going beyond that. So it starts with the total cholesterol, the HDL, the LDL, and triglycerides. That's great information. But we go beyond that into the oxidized LDL, the small dense LDL, the lipoprotein A, and then we're looking at ratios of those in addition to CRP, homocysteine, and then plaque, which tells us about plaque formation. The metabolic panel, we're including glucose, but we're also looking at glycomark, and we're in talks about including an insulin resistance marker as well.
And an insulin resistance marker in the sense of insulin, C-peptide, HOMA calculation, like what does that look like?
I'm going to have to check with the president of the laboratory, because he's got the details on that.
He's got the details on that. Okay. Do you guys, with the cardiometabolic, are you looking at myeloperoxidase?
I'm sorry, can you say again?
Myeloperoxidase, MPO, as part of the cardiometabolic?
We do not include that, no.
And what about the lipoprotein A, as opposed to ApoA? Yeah. Yeah, and that's a pretty standard look.
Yeah, we have apolipoprotein A, apolipoprotein B as well.
And do you guys do like omega-3/6 balance, either separately or as part of that?
We have a fatty acid profile.
And that's what I thought. I'm pretty sure that you did on that. Very cool. All right. So final things, like you have your own clinical experience, and obviously you're also working with and representing the lab. Think about two different functional medicine practitioner types. Think of somebody who's brand new to functional medicine, either because they're just coming out of school with some healthcare degree, or they've been in practice for a while doing conventional things, however they're trained to practice, and now they're new to functional medicine. Give me maybe 2 or 3 tests from the doctor's data stable that you think new doctors, new to functional medicine, should think about doing on, if not a routine basis, some kind of semi-frequency. I always think in terms of tier 1, tier 2, and tier 3 tests, right? Tier 1 are the things that I'm going to do almost always. Tier 2, I do them frequently, but not all the time. Tier 3 is, I do these once in a while. So what would you, as a practitioner and a lab representative, what does doctor's data have that fills that kind of tier 2? These are things that we should all be thinking about doing.
Mm-hmm. Yeah, so I would say the GI 360, actually, just because of that foundational component of the microbiome, and with regards to that dysbiosis index, and also that diversity score, because that is associated with so many health outcomes. Yeah. I like to think of it as, if you go to the orthopedic doctor and you have an issue, they're going to give you an x-ray. They want to see, what's under the hood. So this is akin to that in my philosophy. So I think that does make sense. Yeah.
Yeah. What about, okay, so we'll just leave that as it is. What about seasoned docs that have been doing functional medicine, maybe not using doctors' data or not using them frequently, but they're already doing, good blood work. They're routinely using stool testing, maybe saliva testing for adrenals, blah, blah, blah. What else do you guys have that kind of fit a niche that someone might not be thinking about you guys for that particular service?
Yeah, in those cases, again, it does depend on case history. So I would say we could go through that and see if it's going to be hepatic detox, if it's going to be plasma methylation, if it's going to be amino acid. But I would say along those categories of those more unique cases.
Gotcha.
As opposed to broad-based. So the plasma methylation, and then we do offer amino acid testing, plasma and urinary amino acid testing, that can be helpful as well.
What's the primary application clinically of the amino acid profiles?
So it can be any individual that has potential with amino acid metabolism issues, but it's going to be your patient that is going to tend to be potentially sickly, less diagnosed. You can have patients with neurological conditions, autism spectrum disorders, unique diets. You can have patients that are maybe on feeding tubes, things like that.
And are these, if we see these amino acid imbalances, are they typically phenotypic expressions? Well, I shouldn't say that. Are they inborn errors of metabolism, or are they mostly driven by diet, gut health, absorption, utilization?
Yes, the second. So we're not thinking about inborn errors of metabolism. We're thinking about deficiencies based on health.
Yeah. Correct. Are these people typically like, do they have sarcopenic obesity, or they're cachectic?
Exactly. Yeah.
Yeah, it's kind of wasting away. Yeah, very good. Well, Dr. Julia Malkowski, thank you. I appreciate your time. Any final parting words of wisdom?
No, thank you so much. I really appreciate this discussion today. So it's always a good opportunity to talk about the microbiome. So thank you.
Yeah, well, I appreciate your time, and please extend my thanks to anyone who was part of the decision to have you guys come on and speak your piece with me.